If you want to predict who will develop type 2 diabetes in the next 10 years, forget fasting blood glucose, forget the number on the scale, forget family history. Look instead at a collection of physical signs, signs that are visible, palpable, and in several cases, staring back at the person in the mirror every morning, that indicate insulin resistance is already well underway. Because by the time fasting blood glucose is elevated enough to register as pre-diabetic on a standard blood test, insulin resistance has typically been present for between 5 and 15 years. The laboratory abnormality is not the beginning of the problem. It is the moment the problem became too large to compensate for. Insulin resistance, the state in which cells throughout the body progressively lose their sensitivity to insulin signaling, is the most prevalent metabolic condition in the developed world. Research published in the Journal of the American Medical Association estimates that between 40 and 50% of adults in the United Kingdom and United States have some degree of insulin resistance, the majority without a formal diagnosis, and the majority without any awareness that their metabolic system is already operating under significant strain. They have normal fasting glucose, normal HbA1c, normal cholesterol on a standard panel, and yet their body is working 3 to 4 times harder than it should to maintain those normal numbers, with consequences that are accumulating in the background across every organ system. The 13 signs we are going to discuss today are not theoretical risk markers. They are physical manifestations of the cellular and hormonal disruption that insulin resistance produces long before the standard diagnostic tests become abnormal. They appear in the skin, in the waistline, in sleep patterns, in hunger cycles, in blood pressure readings, and in cognitive performance. And almost universally, they are attributed to something else, to age, to stress, to genetics, to simply being tired. The attribution is understandable. The consequences of leaving it there are not. Your body communicates insulin resistance loudly, and specifically through a language written in physical signs, for years before the blood test confirms the diagnosis. This video is going to teach you that language. We are going to go through all 13 signs, what each one looks like in daily life, what is happening at the cellular and hormonal level that produces it, and at the end, I am going to explain the 3 most powerful and evidence-supported reversals available. Because insulin resistance caught at this stage is not a sentence, it is a warning. And warnings, by definition, are most useful when they arrive early. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years working in A&D, I have seen insulin resistance at every stage of its trajectory, from the incidental finding in a patient who came in for something entirely unrelated, to the full metabolic catastrophe of diabetic ketoacidosis, to the cardiovascular events and end-stage renal failure that represent decades of unaddressed metabolic dysfunction, finally reaching a point of no return. What I have come to understand very clearly is that insulin resistance is not a condition that announces itself with a dramatic onset. It accumulates quietly over years and decades, while producing a consistent and recognizable set of physical signals that the person experiencing them has invariably been given no framework to interpret. My goal now is to provide that framework early enough to matter. If you are watching this video, there is a very good chance that some of what you are about to hear describes your current experience, the hunger that returns too quickly, the fatigue that does not resolve with rest, the waistline that has crept outward despite what feels like reasonable diet and exercise. I promise to keep making videos that connect those experiences to their underlying biological causes, grounded in the science, and explained with a depth your GP rarely has time to provide. All I ask in return is that you give this channel a chance and hit the subscribe button. If you reach the end of this video and you have not learned something that genuinely reframes how you understand your body's current signals, feel entirely free to unsubscribe, no hard feelings. But if you give me your time and attention, I will give you everything I have learned from over a decade in medicine. Please hit subscribe to help this channel reach more people who need this information. And let us get into the science. To understand the signs of insulin resistance, you first need to understand what insulin is actually doing in a healthy metabolic system, because every sign we are going to discuss is the physical expression of one of insulin's normal functions failing to operate correctly. Insulin is produced by the beta cells of the pancreas in response to rising blood glucose, primarily after meals, but also in smaller quantities throughout the day in response to protein, certain fatty acids, and a range of hormonal and neural signals. Its primary role in the commonly understood version of the story is to signal muscle, fat, and liver cells to absorb glucose from the bloodstream, preventing blood sugar from remaining elevated after meals. That part is accurate, but it dramatically undersells what insulin actually does. Insulin is also a growth and storage hormone that regulates protein synthesis in muscle, governs fat storage and fat mobilization in adipose tissue, controls the liver's production of glucose and triglycerides, modulates appetite and satiety signals in the hypothalamus, regulates sodium retention in the kidneys, influences blood vessel tone through endothelial nitric oxide signaling, and affects the function of virtually every organ system in the body through receptor-mediated signaling. It is not a single-purpose molecule. It is a master metabolic regulator with system-wide reach. When cells develop insulin resistance, when the insulin receptors on cell surfaces become less responsive, or when the downstream signaling cascade triggered by those receptors is disrupted, the consequence is not limited to elevated blood glucose. It is a global disruption of insulin's regulatory functions across every system it normally governs. The 13 signs reflect this global disruption. They are not symptoms of high blood sugar. They are symptoms of a master regulatory signal failing to get through. Insulin resistance is not a glucose problem wearing a metabolic costume. It is the progressive failure of the body's most important regulatory hormone to communicate with its target tissues, and the signs of that communication failure appear across every organ system. Insulin normally governs. The reason insulin resistance remains undetected for years through standard medical testing is a specific physiological compensation mechanism that is both the body's strength and its deception. As insulin resistance develops and cells become less responsive to insulin signal, the pancreatic beta cells respond by producing more insulin. More insulin compensates for the reduced cellular sensitivity and maintains blood glucose within normal range. For years, sometimes for more than a decade. The standard diagnostic tests for diabetes and prediabetes measure blood glucose and HbA1c. Both remain normal as long as the beta cells can sustain this compensatory hyperinsulinemia. What is not measured in a standard metabolic panel is fasting insulin, the level of insulin required to maintain normal fasting glucose. A person with early insulin resistance may have a fasting glucose of 4.8 mmol, which is entirely normal, but a fasting insulin of 18 mmol, which indicates that the pancreas is working 3 to 4 times harder than it should to maintain that normal glucose level. The fasting glucose looks reassuring. The fasting insulin, if measured, which it typically is not, tells the real story. Research published in Diabetes Care has demonstrated that measurable insulin resistance, quantified by the HOMA-IR index, a calculation from fasting glucose and fasting insulin, is detectable. An average of 13 years before the development of type 2 diabetes in prospective cohort studies. 13 years of warning. 13 years during which the physical signs we are about to discuss are present and generating signals. And in the majority of cases, 13 years during which those signals are not connected to their cause. Normal blood glucose does not mean normal insulin function. It may mean the pancreas is working extraordinarily hard to produce enough insulin to overcome growing resistance, and the physical signs of that struggle are present long before the glucose number moves. The 13 signs map onto 4 primary mechanisms through which insulin resistance disrupts normal physiology. Understanding these 4 mechanisms allows every sign to be interpreted as evidence of a specific biological failure rather than as a collection of unrelated complaints. The first mechanism is compensatory hyperinsulinemia, the elevated insulin levels the pancreas produces to overcome reduced cellular sensitivity. Chronically elevated insulin has direct physical consequences. It promotes fat storage, particularly in visceral and hepatic depots. It drives the growth of certain skin structures. It activates the sympathetic nervous system and it stimulates androgen production in the ovaries, with reproductive and dermatological consequences. The second mechanism is glucose dysregulation, the erratic blood glucose pattern produced when insulin's glucose-clearing function becomes inefficient. This produces the hunger cycles, energy crashes, and cognitive fluctuations that characterize the daily experience of insulin resistance before formal diagnosis. The third mechanism is dyslipidemia, the specific lipid pattern produced when insulin resistance impairs the liver's regulation of triglyceride and HDL metabolism. Elevated triglycerides and suppressed HDL are among the most sensitive early metabolic markers of insulin resistance, appearing years before glucose abnormalities. The fourth mechanism is systemic inflammation, the chronic low-grade inflammatory state that both contributes to and results from insulin resistance, driving endothelial dysfunction, cardiovascular risk, and a range of physical signs including fatigue, cognitive impairment, and skin changes. The first and most visible sign of developing insulin resistance is the accumulation of fat in the abdominal region, specifically visceral fat, the fat that deposits around and within the abdominal organs rather than subcutaneously beneath the skin. This is not simply a matter of excess caloric intake, it is a direct hormonal consequence of chronically elevated insulin. Insulin is a potent promoter of lipogenesis, fat synthesis and storage, and inhibitor of lipolysis, fat breakdown. When insulin is chronically elevated due to compensatory hyperinsulinemia, the balance tips permanently toward fat storage. Visceral adipose tissue has a particularly high density of insulin receptors and responds to chronic insulin elevation by preferentially accumulating triglycerides. The result is the characteristic central obesity, a waistline that expands despite what feels like moderate caloric intake, and that is resistant to reduction through conventional calorie restriction because the hormonal driver of the fat storage remains unaddressed. The clinical significance of visceral fat extends beyond its role as a sign. Visceral adipose tissue is metabolically active. It releases free fatty acids into the portal circulation, driving hepatic insulin resistance and triglyceride overproduction. And it secretes pro-inflammatory cytokines, including TNF-alpha and IL-6, that amplify the systemic insulin resistance affecting other tissues. It is simultaneously a consequence and an accelerant of the condition producing it. A waistline above 94 centimeters in men or 80 centimeters in women is not primarily an aesthetic concern. It is the most accessible clinical marker of visceral adiposity. And visceral adiposity is both a sign and a driver of insulin resistance operating through direct, metabolic, and inflammatory mechanisms. Acanthosis nigricans is one of the most diagnostically specific physical signs of insulin resistance, and one that is remarkably common, yet most people who have it have never been told what it means. It presents as a darkening and thickening of the skin in body folds and creases, the back of the neck, the armpits, the groin, and sometimes the knuckles and elbows. The affected skin has a velvety texture and a grey-brown pigmentation that does not wash off and that may be confused with poor hygiene or sun damage. The mechanism is direct. Chronically elevated insulin activates insulin-like growth factor receptors on keratinocytes, the primary cells of the skin's outer layer, stimulating their abnormal proliferation and the overproduction of melanin. The darkening and thickening is a growth response driven by hyperinsulinemia. Research published in Diabetes Care has found that acanthosis nigricans correlates more strongly with fasting insulin levels than with fasting glucose levels, confirming that it is a sign of insulin excess rather than glucose excess, and therefore appearing years before glucose abnormalities develop. Darkened velvety skin at the back of the neck or in the armpits is not a skin condition requiring a dermatological referral. It is insulin writing its excess directly onto the surface of the body, and it deserves a metabolic blood test, not a topical cream. Skin tags, small, soft, flesh-colored, or slightly darker growths that appear most commonly in the armpits, neck, eyelids, and groin, share the same mechanistic origin as acanthosis nigricans. They are a proliferative skin response to chronically elevated insulin, stimulating insulin-like growth factor receptors on fibroblasts and keratinocytes. Research published in the Journal of the European Academy of Dermatology and Venereology found that the number of skin tags correlates significantly with fasting insulin levels, HOMA-IR scores, and the presence of metabolic syndrome independent of age and body weight. The practical implication is that while individual skin tags are benign and common in the general population, their presence in significant numbers, particularly in someone who is also experiencing other signs on this list, constitutes a metabolic signal worth investigating. A person with multiple skin tags, a thickening neck crease, central adiposity, and persistent afternoon fatigue is presenting a coherent physical picture of insulin resistance that a simple blood panel would confirm or clarify. The fatigue of developing insulin resistance has a characteristic pattern that distinguishes it from the generalized tiredness of poor sleep or overwork. It is specifically postprandial, most pronounced in the 1 to 3 hours following meals, particularly meals high in refined carbohydrates and sugar. It is the afternoon slump that reliably appears after lunch, the heaviness and cognitive dulling that descends mid-morning after a cereal breakfast, the inexplicable need to rest after eating that seems disproportionate to the meal consumed. The mechanism is glucose dysregulation. When insulin resistance reduces the efficiency of post-meal glucose clearance, blood glucose spikes higher and remains elevated longer than it should. The compensatory hyperinsulinemia that follows drives blood glucose down sharply, often to below the pre-meal level in a reactive hypoglycemic pattern. The cells of the brain, which are acutely sensitive to falling glucose levels, experience this as an energy deficit that manifests as cognitive slowing, drowsiness, and the overwhelming desire to sit or lie down. This is not laziness. It is the brain's rational response to a suboptimal fuel supply. Post-meal fatigue is not a normal consequence of eating. It is the body's signal that the fuel from that meal was not managed efficiently, that blood sugar spiked too high, fell too fast, and left the brain momentarily undersupplied in the process. The carbohydrate cravings experienced by people with developing insulin resistance are not a failure of willpower or a psychological weakness. They are a direct physiological consequence of the glucose dysregulation cycle described above. When blood glucose falls rapidly following the compensatory insulin surge, the reactive hypoglycemic pattern that follows the exaggerated post-meal spike, the hypothalamus detects falling glucose levels and generates a powerful drive toward rapid glucose replacement. The body is experiencing a genuine, biologically urgent signal for fast carbohydrate, and it generates exactly the craving profile that reliably delivers it: sweet foods, starchy snacks, biscuits with afternoon tea. The insidious dimension of this cycle is its self-reinforcing nature. The carbohydrate snack consumed in response to the craving produces another glucose spike, another compensatory insulin surge, another reactive fall, and another craving, typically within 90 minutes to 2 hours. The person cycling through this pattern is not overeating from poor discipline. They are responding to a physiologically generated hunger signal that is the direct consequence of dysfunctional glucose metabolism. The cycle cannot be broken through willpower alone because the drive is hormonal, not volitional. This sign is one that may already be present in a viewer's medical records without having been explained in the context of insulin resistance. A fasting triglyceride level above 1.7 mm SLAL, the threshold at which current guidelines consider triglycerides elevated, is one of the earliest and most sensitive metabolic markers of insulin. Resistance, appearing in many cases years before fasting glucose becomes abnormal. The mechanism is hepatic. Insulin resistance in the liver impairs the normal suppression of VLDL production that insulin ordinarily provides after meals. The insulin-resistant liver continues producing and secreting VLDL, the triglyceride-rich lipoprotein particle, even in the presence of elevated insulin, because it is not responding normally to insulin's signal. The result is persistently elevated circulating triglycerides, even in a fasted state. Simultaneously, insulin resistance impairs the enzyme lipoprotein lipase, which normally clears triglycerides from the circulation, further compounding the elevation. A fasting triglyceride level that has been rising on successive blood tests over several years, even if still within the normal range on an individual reading, is a trajectory worth discussing, with a clinician in the specific context of insulin-resistant screening. HDL cholesterol, high-density lipoprotein, the particle responsible for reverse cholesterol transport, removing cholesterol from arterial walls and returning it to the liver for processing, is consistently suppressed in the context of insulin resistance through a mechanism directly linked to the triglyceride elevation described above. When VLDL triglycerides are chronically elevated, a process called cholesterol ester transfer protein activity accelerates the exchange of triglycerides from VLDL into HDL particles, replacing the cholesterol that gives HDL its functional density. The result is a population of smaller, denser, triglyceride-rich HDL particles that are cleared from the circulation more rapidly, producing the characteristic low HDL reading of the metabolic syndrome. The combination of elevated triglycerides and suppressed HDL is known as the atherogenic dyslipidemia of insulin resistance, and it is a far stronger predictor of cardiovascular risk isolated LDL elevation. Yet it receives a fraction of the clinical and public health attention. Research published in Circulation has established that the triglyceride to HDL ratio is among the most accurate surrogate markers for insulin resistance, measurable from a standard lipid panel, more sensitive in many studies than fasting glucose alone. If your blood test shows triglycerides creeping up and HDL creeping down over successive annual reviews, you are watching insulin resistance developing in real time through the lipid panel, even if your glucose and HbA1c remain unremarkable. Just very quickly, if you are finding this useful, please consider hitting the subscribe button. It genuinely helps this channel reach more people who need this information. We are just over halfway through the 13 signs. Let us continue. Hypertension is both a consequence and an amplifier of insulin resistance, operating through several mechanisms that make the relationship bidirectional. The primary mechanism is renal sodium retention. Chronically elevated insulin stimulates sodium reabsorption in the proximal tubule of the kidney, increasing blood volume and raising blood pressure through a pathway entirely independent of dietary salt intake. This is why some patients with salt-resistant hypertension, blood pressure that does not meaningfully respond to sodium restriction, improves significantly when insulin resistance is addressed, rather than when sodium intake is further reduced. The second mechanism is sympathetic nervous system activation. Hyperinsulinemia directly stimulates sympathetic tone, raising both heart rate and peripheral vascular resistance. The third is endothelial dysfunction. Elevated insulin reduces nitric oxide bioavailability in blood vessel walls, impairing the vasodilatory capacity that normally limits resting pressure. The diastolic reading, the lower number representing the minimum pressure between heartbeats, is often the first to rise in early insulin resistance, reflecting the sustained elevated vascular tone produced by these mechanisms even during cardiac relaxation. The cognitive manifestation of insulin resistance is among the most distressing for the people experiencing it and among the most consistently dismissed as a normal consequence of aging or a busy lifestyle. It presents as a difficulty sustaining concentration, a slowing of mental processing speed, a tendency to lose the thread of a sentence or conversation midway through, and a specific difficulty retrieving words that were previously immediately accessible. These are not features of early dementia. They are features of a brain operating in a suboptimal metabolic environment. The mechanism is twofold. The first component is the glucose dysregulation, described under fatigue. The brain consumes approximately 20% of the body's resting glucose, despite representing only 2% of body weight. In the glucose dysregulation cycle of insulin resistance, spikes followed by reactive falls, the brain experiences repeated periods of relative energy insufficiency that impair the metabolic requirements of sustained cognitive function. The second component is cerebral insulin signaling. The hippocampus and prefrontal cortex, the brain regions most critical for memory consolidation and executive function, have a high density of insulin receptors. And impaired insulin signaling in these regions directly disrupts the synaptic plasticity mechanisms underlying learning and memory. Research published in the Journal of Clinical Investigation has demonstrated that experimental induction of insulin resistance in healthy volunteers produces measurable cognitive impairment within weeks, reversible upon restoration of insulin sensitivity. This is the sign that most commonly brings people to their GP, and that is most commonly met with advice to try harder, to reduce calories further, to increase exercise intensity. Advice that fundamentally misunderstands the hormonal reality of insulin resistance as a metabolic state. When insulin is chronically elevated due to compensatory hyperinsulinemia, the adipocytes, fat cells, are in a physiologically enforced storage mode. Lipolysis, the breakdown and release of stored fat, is directly suppressed by insulin. A person whose insulin is elevated throughout most of the day, as is typical in established insulin resistance, is biologically unable to efficiently mobilize their stored fat for energy, regardless of their caloric deficit. The result is the deeply frustrating experience of genuine dietary effort producing minimal fat loss, because the effort is addressing the fuel intake while the hormonal environment has locked the fuel storage tank. Caloric restriction in the context of persistent hyperinsulinemia produces muscle loss and metabolic rate reduction before meaningful fat loss occurs. This is not a metabolic peculiarity, it is the predictable consequence of trying to empty a storage system whose locking mechanism is hormonal rather than caloric. Addressing insulin resistance through the dietary and lifestyle interventions that lower insulin levels is the prerequisite to effective fat loss, not a supplement to calorie counting. Insulin resistance has profound and distinct hormonal consequences in both sexes that are among the most personally impactful signs on this list. In women, chronically elevated insulin stimulates the ovarian Thurker cells to produce excess androgens, male sex hormones, through a mechanism that directly involves insulin receptor activation in ovarian tissue. The result is the cluster of symptoms associated with polycystic ovary syndrome, irregular or absent menstrual cycles, acne, excess facial or body hair, and in many cases, the ultrasound finding of multiple small ovarian follicles. Research published in the New England Journal of Medicine has established that insulin resistance is present in approximately 70% of women with PCOS, regardless of body weight, confirming that PCOS is primarily a metabolic condition with reproductive manifestations, rather than a gynecological condition with metabolic associations. In men, the consequences of insulin resistance on sex hormone biology operate through a different pathway. Elevated insulin suppresses sex hormone binding globulin, the protein that transports testosterone in the bloodstream, reducing the bioavailable fraction of testosterone available to tissues. Simultaneously, the visceral adipose tissue that accumulates in insulin resistance converts testosterone to estrogen through the enzyme aromatase. The combined result is a decline in functional testosterone levels that manifests as reduced energy, reduced libido, difficulty building or maintaining muscle mass, and in some cases mood changes and depression. This hormonal consequence of insulin resistance is present across a much wider age range than the conventional framing of testosterone decline, as a simple aging phenomenon would suggest.